Once you've done your preparation in your practice and then built some of the skills and tools, and you've started to develop an approach to your care and patient engagement, you need to have a really good approach to care planning. And luckily, there's a well researched approach called collaborative care management. Not only has it been done in research practices, but it's been done throughout the country in real practices like yours. And these people who've done the work in this area, many of whom are involved with NRI, have an approach that involves patient-centered care, population-based care, measurement and treatment to target, using evidence to adjust care, and then being accountable, both in terms of making sure that patients respond, but also making sure that your practice has a sustainable effort. So what you want is well-trained and supported care managers in your practice, a systematic approach to monitoring and follow-up, and you want direct communication with providers so they know what's going on as part of the collaborative care team. First step in that work, if we go to the next one, is to have an approach to risk stratification with behavioral health problems. This is an example of how we approach patients who have depression and using the PHQ-9 tool. We use risk stratification all the time with other diseases, medical diseases. There's no reason we can't use the same approach here. Is it cookbook? Well, you could say that it is, but the JNC recommendations about blood pressure, the ADA's recommendations about glucose control, you could say those are recipes as well. The fact is that they're recipes that have been well tested. Why shouldn't we use them to cook with? That doesn't mean we can't use our own approaches to making a more flexible and adaptable approaches. And as you see in the treatment recommendations, it's not just one thing there, but it gives you an idea about the intensity of work to put in. So that in addition to doing risk stratification to decide who to put the most effort into, we need to have a step care approach. And again, this is the way we've been doing hypertension care for years. And what we tried to do in our office was to set up a similar kind of approach for depression care. So on the back of the PHQ-9 that we use when we're using the paper is for the clinician, we have guidelines about the various common drugs we use and also ways to augment and adjust therapy based on PHQ-9 responses. This makes it very easy for your clinical staff to take over responsibilities for patients with depression that don't require intervention by a psychiatrist or a behavioral health team. What I've given you here that you can take a look at from the slide deck is what it ought to look like in your behavioral health agency, how they respond to someone that you refer or that they're caring for with depressive disorder. And the idea is how do you evaluate the help that you're getting from your behavioral health agencies using this process map will give you an idea about what you're looking for, making sure, and you can help them understand where you want to know how things are going on. The fact is that even though you've referred the patient to a behavioral health organization, you are still taking care of the patient with their chronic diseases, and you need to know about interactions with their drugs and their other therapy. An important part of care beyond medications is to activate the patient's natural supports and what are now called personal medicines. I've been running diabetes support groups for about 15 years, and I discovered all the secrets that people have about how they really take care of themselves after they leave my office. And it turns out that there are many people in their lives whose opinions about their care are just as important as mine. There are people who provide them solace and companionship, life interest that are much more effective than the medications in my pill bottles. So understanding who those people are in their lives, helping to activate friendships and activities are essential for patients, not only those who are depressed, but particularly those who are depressed. And again, beginning to understand what are the ways you respond to these stresses in your lives and augmenting those with your therapy rather than trying to replace them is very important. One of the ways we've done that in our support groups and in our exam rooms is to help patients make decisions about specific action steps they want to take. So this is a document that helps them choose a goal for themselves and then has a number of different kinds of recommendations which actually were developed in our discussions with our support groups, things that they could try to see if they have better results in reaching those goals. Those become part of the patient's record so that the next time they come in and said, see, last time you were here, you said you were going to try to substitute some low-salt snacks for what you've been using. How did that work out for you? Or that you wanted to walk around the reservoir, or that you were planning to go to Bible study, or maybe that you were going to be making a list of your pleasurable activities. The idea is the patient sets their goals, you help them choose an action step, and in your future visits, you refer to their goals and their action steps and help them discuss the obstacles they've run into, but also to reinforce their successes. This creates the environment for the patient that when they come to see you, they're there to report on the work they're doing. Because after all, health happens in between doctor's visits, not at the doctor's visit. Next slide. We are kind of in a transition now about developing care plans. Some of your EHRs, because of the PCMH push, do in fact have some place to put in the patient's care plan using the SMART approach, where people indicate what it is they want to do, when they want to do it, how they want to do it, when they're going to be done doing it, and what their confidence is that they can do it. But that's a new thing for us, to have the patient's own problem and activity list rather than only our own. But this is going to become more and more common. And not only that, we're going to need to be able to share these plans across the various silos that presently exist in medical care. You're going to need to know what's going on at the behavioral health agency for your patient, at the social service programs, at the exercise programs. Just go down the list of all the different things people need to be doing for their health. And being able to have that coordinated by one of your staff so that you can be augmenting that work rather than having to be responsible for all of it is really a great idea. But we're going to need some help in doing that. I've shown on this slide one article that I found useful, beginning to think about engaging patients in collaborative care.